All right, you're good to go.
All right, thank you. Thank you, Josh, for the invitation. I'm Nick Fiedelman. I'm an interventional radiologist at UCSF, and the topic for today's presentation is the histotripsy treatment and its availability at UCSF. Histotripsy is a non-invasive local tumor treatment. It involves delivering short bursts of ultrasound energy that lasts microseconds that leads to a process called cavitation from presence of gas in tissues. Gas is normally present in tissues, and during cavitation, uh, tiny microscopic bubbles form and collapse. And as a result of this rapid expansion of microbubbles, anywhere from about 2 to 5 nanometers to 100 microns in size, so these bubbles rapidly expand, and as they expand, they fracture cellular components and essentially cause liquefaction of tissue. This is the setup for the procedure. There's several components that are involved. The ultrasound for histotripsy is delivered by this robot in the center that also has an embedded ultrasound probe in it. So the tumor to be treated is visible by ultrasound. And this ultrasound energy has to be delivered through a specially placed water bath. So there's a bag here, a membrane, a clear membrane, plastic membrane that's full of water, and it's placed over a person's abdomen to be able to visualize the tumor and to deliver this ultrasound energy. Ultrasound does not travel through air. It has to travel through water. That's the purpose of this water membrane. There's also a regular ultrasound machine with this setup for diagnostic purposes to be able to find the appropriate area to treat correctly. And the last piece of equipment is a special machine that degasses the water. So we don't want gas inside the water because that impedes, prevents ultrasound waves from traveling. And so the water that's placed inside this membrane is actually undergoing a process of degassing before it's poured in there. This is what it might look like when this energy is being delivered. In reality, this area is this cavitation process that you're seeing in action. This thing is the size of a grain of rice, and so these little grains of rice are being ablated in concentric circles until the entire tumor is treated. And so in the process of treatment, we have to define 7 points around the volume that needs to be treated. What you're seeing here is a piece of cow liver that's embedded inside a gel material. And at 10 times the speed that the machine is delivering its histosonic energy. And you can see these grains of rice slowly overlapping and slowly filling the entire prescribed volume. And that volume can be a sphere, it can be an ellipse, but it has to be has this like rounded appearance. And so once this is over, you see what happened to that tissue. That tissue became liquid. You see, it just poured out. And the actual gel is intact. And so here's an example of what it might look like for the actual treatment. This is one of the first people who was treated with histotripsy on the clinical trial. This was the tumor in the red circle. And here's the histotripsy being done. Let me play this video. So what you're looking at the little red plus is that white bubble cloud that indicates that cavitation is happening. So this is that grain of rice that's moving continuously through the prescribed treatment volume, and the prescribed treatment volume is in that red circle. And then after the treatment is completed, it looks like this area of dead tissue. There is no contrast material going to that area. That area of tissue contains completely dead material. There's nothing alive left in there. It's entirely treated. If somebody was to look under microscope, what happens after histotripsy treatment, they might find something like this. So to orient everyone, this red stuff in the center is dead tissue. So that's the tissue that was liquefied. This bluish stuff around it is just an inflammatory reaction to the dead tissue. And then you're going into the normal liver out here. And this is an analysis from a pig liver that was treated with, an area was treated with histotripsy, and this is what you can see under the microscope. What we also found out was that the energy it takes to kill a tumor is less compared to the energy required to damage structures such as veins and bile ducts. So during the histotripsy treatment, tumor tissue is disproportionately destroyed, whereas bile ducts and vessels are typically spared. And so what you're seeing here on this MRI scan is that the tumor itself is dead, but there is a bile duct going right through it that's completely intact and has not been damaged. And these are pictures again from a pig liver showing that there is areas of dead liver tissue, but entirely normal bile ducts and vessels completely preserved. A few more examples of what happens to these treated tumors over time. So here's another tumor, an area of treatment, tumor completely dead, and then that area of dead tissue pretty rapidly involutes. Just 1 month after, it becomes very small again. Another example, 36 hours after treatment, and then 6 months out, barely visible. And another one, 36 hours after treatment, and then 1 year out, barely visible. So here's where we are at this point with histotripsy experience. The company, Histosonics, reports that over 2,300 procedures have been completed. Most of the physicians who perform these procedures are either interventional radiologists or surgeons, about 50-50 split. And majority of the tumors that have been treated to date were colon cancer spread to the liver, primary bile duct cancers, and neuroendocrine tumors, as well as primary liver cancer. So those would probably be the most common 4 so far. And the parts of the liver that are particularly visible by ultrasound is the bottom half of the liver. So the liver segments or sectors that are best visualized by ultrasound are located in the bottom half of the liver. So those are sectors number 3, number 4, number 5, and number 6. That's why most of the tumors, percentage-wise, were treated in those sectors. The other liver sectors are higher up. They tend to be more difficult to visualize with ultrasound, and therefore they haven't been as common targets. There is not a lot of data behind using histotripsy. The first study that came out was called Teresa feasibility trial. Only 8 patients, 11 tumors. This was a proof of concept, so to say, study where they were just trying to show that this treatment was effective and that was working. And they reported 100% technical success of actually being able to treat the targeted tumors. And 90% of those tumors had significant involution at 8 weeks. Then came out the Hope for Liver trial, which actually led to FDA approval of histotripsy technology. This one included 44 people, liver metastases for 26, and primary liver cancer in 18 of them. Average tumor diameter was 1.5 centimeters, so just over 1/2 inch in size for the tumor diameter. The technical success rate was very high, again, nearly 100%. So they were able to treat, I think, all but one of the targeted tumors successfully. The severe side effects were an infection in the bile duct, pain in the chest area, as well as there's one instance of liver failing, but that was thought to be due to cancer getting worse, not to the actual treatment. Non-serious side effects were abdominal pain in about a quarter of people, mild abdominal pain, I should say, fevers that went away with just supportive treatment like Tylenol, and feeling tired or fatigue. A follow-up study published more recently showed that of those people who had follow-up after a year after their original histotripsy treatment, the treatment was still durable. There was no tumor regrowth after 1 year in 90% of them. Another recent study looked specifically at safety of 230 histotripsy treatments from multiple centers. This data was pulled. And what they found that majority of the patients had no side effects. There were some minor side effects like skin irritation. And then there were also some side effects related to formation of blood clots in the area of the tumors. And that's something that we now know to expect. And actually, if we're going to be treating next to a major vessel inside the liver, we would be giving those people a blood thinning medication to prevent blood clot from forming. There were also one instance of kidney damage, which was fortunately reversible. It wasn't permanent, but there was that problem. And that's something that we're now recognizing. A little bit more on that in just a few minutes. There was also one death in that study, and that was because of there were 3 deaths. Those were because of the cancer getting worse, not because of the treatment itself. There were no deaths related to the treatment. So how do we select people for histotripsy treatment, and what are some guiding principles that we use for selecting people for treatment? Number one, first and foremost, the tumor has to be visible by ultrasound. If it's not visible by ultrasound, we cannot reliably see it and we cannot reliably treat it. Now, you might hear that some people are using some additional imaging methods to try to triangulate, for lack of a better term, from where they would expect the tumor to be located to some normal anatomic structures like blood vessels. But that is not 100% reliable, and what we want to do is deliver precise treatments to the tumors and not to healthy liver tissue. The machine is able to deliver its energy up to 12 centimeters in depth. So if the tumor is located more than 12 centimeters from the skin surface, it probably will not be able to be treated because that's too deep for the machine to reach. Tumor sizes that we can treat are probably up to about 4 centimeters to 5 centimeters in size, understanding that something this big would probably have to be treated in 2 separate sessions potentially, because there could potentially be some treatment-related side effects if we treated too much all at once in one sitting. Because of this finding that liver tissue is more sensitive to this histotripsy technology than healthy bile ducts, veins, and surrounding structures, we can treat close to the stomach, close to the intestine, close to the gallbladder, kidney, and liver surface. And we can also treat central tumors. And central tumors are the ones that tend to be difficult to treat with other local treatments. Local radiation treatment can be a problem for central tumors because it involves radiating large areas of healthy liver in order to get to that central area. Treatment with arterial treatments like chemoembolization, blend embolization, and radioembolization can be tricky because then you have to potentially treat very large areas of normal liver tissue in order to get that central area entirely. And ablation there is hard because of the proximity to the vessels and the ducts. And histotripsy seems to be able to treat tumors despite proximity to the vessels and the ducts, and so those central tumors seem to be particularly good targets for histotripsy. Typically, these procedures may be between 2 and 5 hours in length. They can be quite lengthy. It can take a while to make sure that the correct zone is being treated. And if overlapping treatments need to be delivered, then each time this planning process has to be repeated. And these treatment can take a while. They're done with general anesthesia. Why? Is because we definitely don't want the liver and the tumor to move too much during the treatment. In fact, ideally, we don't want any movement. And as you might imagine, liver moves quite a bit with breathing. And so we really want to minimize breathing motion. The way we do it is we do something called double lumen intubation, a placement of a breathing tube into the left bronchus, so just breathing the left lung and allowing the right lung to kind of partially collapse so that the right lung is not moving. As a result, the liver is not being pushed by the right lung, and everything that's in the liver becomes fairly stationary. For people who have had work done on their bile ducts, like a Whipple procedure or ERCP or a bile duct stent, these people might be at potentially at an increased risk of bile duct infection or an abscess. So for them, we would prescribe an antibiotic for a period of about 17 days. And then lastly, we want to do everything to prevent those kidney injuries that could potentially occur. And so we give a lot of IV fluid before, during, and after the procedure, and actually place a catheter in the bladder or a Foley catheter to monitor urine output and to make sure that we're not seeing any blood in the urine during the procedure. So how do we select people in terms of tumor sizes, tumor numbers? So generally speaking, histotripsy you can think of as an alternative to ablation. So that's basically being very pinpoint to 1, 2, maybe 3 areas during a single treatment and destroying those areas one at a time. Histotripsy can be used to treat metastatic tumors like neuroendocrine tumors or tumors that start in the liver like primary liver cancer. It can also be used as an adjunct. So for instance, if we treated a big tumor with radioembolization or Y90 treatment or with chemoembolization, there could be 1 or 2 small tumors in the outer liver lobe that we could treat with histotripsy just so that we don't expose all that healthy liver to chemotherapy, to radiation, to prevent damage to healthy liver tissue. We can be a bit more pinpoint by delivering histotripsy or using ablation for the smaller tumors on the other side of the liver. Generally, these tumors would not be treatable with surgery because if surgery is possible, then it's usually preferred. Tumors would be predominantly located in the liver or only located in the liver, while the tumors outside of the liver would either be stable and not causing any symptoms, so that it would make sense to focus on the liver treatments. These tumors for histotripsy should be in the not in favorable location for other established treatments. So for instance, if a tumor is easily treatable with microwave ablation, which is a very established technique that's been around for decades at this point, it should be treated with ablation because we know a lot more about safety and effectiveness of ablation. If it's, say, a bigger tumor and it's in the periphery of the liver that would be successfully treated with the chemoembolization, it should be treated with chemoembolization. It should not be treated with histotripsy. Histotripsy should be saved for tumors that are in a difficult location for another local treatment, and where other local treatments are likely to be either impossible to do or unsafe. So these tumors have to be visible by ultrasound, so they'll usually be in the kind of bottom 2/3 to bottom half of the liver. And the tumors located in the upper liver probably wouldn't be visible. As I mentioned, next to stomach, bowel, gallbladder, kidney, and liver surface is acceptable. Central tumors are particularly well suited for histotripsy, and I'll show you a couple examples. We can safely treat people who have had work done on their bile ducts, who might be at an increased risk for an abscess with other treatment modalities. And as it turns out, presence of fluid around the liver or ascites is acceptable. As long as we can visualize the tumor well with ultrasound, it should be safe to treat. And people who are taking blood thinning medication don't have to stop taking blood thinning medication. In fact, we'll be giving them blood thinning medication oftentimes during the treatment if the tumor is located next to a major liver vessel. So here's a couple examples of people that I have treated since we started our program at UCSF in June. As you see, these tumors are located in the central part of the liver. So there is a tumor. There are some normal bile ducts kind of all around it, normal vessels all around it, and this tumor is in a very central location. Delivering radiation to this tumor would involve radiating all of this healthy liver tissue. Doing an embolization of this treatment would be hard because the vascular territory would also probably involve the entire right lobe of the liver. So that's really a lot. This tumor here is located in what's called the caudate lobe. That area of the liver is notoriously difficult to treat by vascular means like chemoembolization and radioembolization because the blood vessels to this area are usually very small, very tortuous, very difficult to get the little catheter into those blood vessels. And so this person actually had Y90 or radioembolization treatment. All the tumors have shrunk with the Y90 treatment except for this one. And so this one was the one that we decided we should treat with something. It started to grow, and because of its central location next to the vessels, next to the bile ducts, very deep inside the liver, we decided that histotripsy might actually be the safest possible treatment there. Another example of a good tumor for histotripsy, this one is located right next to the bile duct. The bile duct is with the yellow arrows. That's where the bile duct runs, and there is also a vessel running right next to it. So to spare these structures, doing histotripsy in this area would be good. And as you can see, it's not very far from the liver surface, should be visible by ultrasound. So where are we going from here? There is ongoing clinical trials looking at treatment of kidney and pancreas tumors. There is also, as I mentioned at the beginning, a potential for using fusion technologies, imaging fusion technologies, where a CT scan or an MRI scan is fused together with an ultrasound to basically tell you where the tumor is located, even though it's invisible by ultrasound. But more work is definitely required in that realm before we can reliably use MRIs and CT scans obtained on a different day, fused with ultrasound for navigation of the histotripsy treatment. And then also there's a possibility of activation of the immune system. There is some work in mice that has been done, actually, that comparing different local treatment techniques that suggests that histotripsy may be more immunogenic than thermal ablation, like radiofrequency ablation, may be more immunogenic than external beam radiation. So what do we tell our colleagues about how to refer someone for histotripsy? There's two potential pathways. One would be to refer someone for liver tumor treatment in general. That would generate an interventional radiology consultation where we review different possibilities. And if we think that histotripsy is the best answer, then that's what we would recommend. We would perform a screening ultrasound, and that's not done on the treatment day. That's done separately as a separate visit, and answer any additional questions in another consultation. And this screening ultrasound is actually performed by the interventional radiology doctor to make sure that the doctor themselves knows exactly how to visualize this tumor in the best way. And we also know what that treatment robot is capable of achieving in terms of angles. So angulation becomes very important in the way the images are generated. And so since we know what the robot is capable of, it's important that we ourselves do the test, not a technologist. The second pathway is that the referral that we receive is specifically for histotripsy. It's already been reviewed and other treatment modalities were thought not to be helpful. If this person is new to our clinic or new to our interventional radiology service, we would do kind of a behind the scenes chart review the imaging, and make sure that histotripsy is likely to help. And if so, we just go directly to that focused ultrasound and a consultation. And if it looks like the area is visible by ultrasound and the treatment is appropriate, then we go ahead and schedule the treatment. And that's all I have today. Thank you. I'll take any questions.
Nick, looks to be my fault that I got the wrong link. I got the right link to us and the wrong link to everyone else, but we did have people join us both on YouTube and on this channel as well. So far I'm waiting for anyone to have questions, but I'll ask a few. I think, you know, certainly a lot of the community has looked in, certainly in the NETS community, as this is a, you know, kind of risk-free, non-invasive way to attack tumors. And I think inside of your presentation, you certainly had, you know, kind of a hierarchy of if you can get to it via things that we know and have long-standing understanding of how they work, and they're viable, that you should probably do those first. How does, you know, how do you see that evolving? And do you see a pathway where you're going to be recommending histotripsy before other modalities that have been around for longer, or what would that take?
That's a great question. What it would take is first and foremost more data. It would take more information on how safe and how effective histotripsy is. I showed you the extent of the effectiveness data that we have. One study of 8 patients and another study of 44 patients. So that's just over 50 people who've been treated with histotripsy on clinical trial in a prospective manner, where we actually have a reliable safety and effectiveness data. So we have to have a lot more information in order to start recommending histotripsy for tumors that would be suitable for other forms of treatment, like chemoembolization or ablation. As far as safety, we're learning as we go. And what we're learning from our early experience, and as I mentioned, our program started really in June. The first person we treated was at the end of June at UCSF, and since that time we've treated 7 people, 2 with neuroendocrine tumors. What we've learned is that issue of having blood in the urine is actually very common, because we are following our patients meticulously, and everybody has been getting bladder catheters. And we've been noticing that actually 6 out of 7 of them have had blood in the urine. And kidney failure can happen. We had one person develop kidney failure, fortunately recovered fully, but nevertheless, it happens. And it might actually happen more frequently than these earlier studies were alluding. So these are potentially serious side effects that could really affect someone's health in the long term, potentially. And so I think we have to be very judicious about how we apply this treatment now as we're learning. I think it is reasonable to do this treatment when other treatments may not be possible, may not be safe, and we need to do a local treatment really does make sense. But we have to be judicious about how we apply it right now.
And looking at how you were recommending it, it seemed to be you were looking at even in places where, you had multiple tumors that you were first looking at doing either the Y90 or chemoembolization or whatever other treatment first to bring down the tumor volume, and or eliminate all the pathways other than those for histotripsy before you did histotripsy. Is that
Right, right. So one example that I showed was somebody who had, say, one big tumor or several big tumors, clearly way too big for histotripsy. But we can treat those very effectively with Y90 radioembolization or with chemoembolization or with blend embolization. We can decrease them in size drastically. And then in the other part of the liver, there might be tumors that are also growing, but there's only, say, one or two tumors, and the rest of that liver is completely healthy. So this is not where we would necessarily want to give arterial treatment, because that means that this material, the chemotherapy or the radiation, would go to a lot of the healthy liver tissue on the other side, where we want to be much more pinpoint. We want to limit the treatment as much as possible to just the area of the tumor and maybe just a small margin of healthy liver tissue around it. And that's where we might start thinking about ablation, or we might start thinking about histotripsy in those areas, yes. Or if after, say, chemoembolization, there is still a nodule of tissue that's remaining, that's viable, that we want to go after, and then maybe histotripsy would make sense there.
And you've talked about prospective clinical trials to get you more data. Do you know if any of them are going to be segmented off into neuroendocrine tumor subgroups?
Great question. So right now, the company has trials in kidney and in pancreas. They're actually not clinical trials for liver metastases, and so this would have to be a whole new clinical trial that would need to be put together for liver metastases, and it might make sense to make it limited to people with neuroendocrine tumors, but that's not even underway yet.
Right. So the 54, I think that you mentioned on the original trial to get the machine approved had what, about six net patients in it?
Yeah, maybe like yeah, maybe about 20%. Yeah, so about maybe 10.
Okay. Um, so not seeing any other questions from the audience, at least that they're chatting. I'm gonna stop the recording here in a second and let people turn on their cameras and at least say hello and maybe ask more informally, but we'll turn off the recordings and get this on live. So first of all, thank you for coming, and to all those who are watching this recording because they couldn't watch it live due to my error. I apologize, but we'll continue to work on getting these things right.